Hi, I'm Prithviraj Bose. I'm a professor in the Department of Leukemia at MD Anderson Cancer Center in Houston, Texas. I focus on myeloproliferative neoplasms. Prefibrotic primary myelofibrosis is what could be called a prodromal phase of myelofibrosis where patients are early in the disease, and this is increasingly diagnosed on bone marrow biopsy because it is now a individual, its own entity, I should say, in the WHO classification of myeloid neoplasms. It used to be a provisional entity, but now it's its own thing, and therefore, more and more we see bone marrow reports that call out this diagnosis. So I think it's going to be increasingly apparent that a lot of patients present with this phase of the disease. The outcome of prefibrotic primary myelofibrosis is certainly better than that of overt primary myelofibrosis, with a median survival of around 15 years. But it is not as good as that of essential thrombocythemia, which is what these patients used to be felt to have. In fact, one of the seminal publications by Professor Barboui back in 2011 really carved out this diagnosis from a group of patients who were thought to have ET. So the point here being that this is a more serious diagnosis than ET. ET in general has a normal survival, whereas this clearly doesn't. The Italians have published around 15 years median, but it is certainly better than overt primary myelofibrosis. So one, we are seeing it increasingly. Two, it seems to be its own thing in terms of prognosis, somewhere between ET and overt primary myelofibrosis. And three, maybe we can intervene early when people are in this stage of the disease, i.e. prefibrotic. And that is increasingly, I think, going to be an area of investigation. There are definitely diagnostic challenges, but those are primarily pathologic and not so much, something that the clinician would face. But this absolutely requires pathologic expertise. In expert pathologist hands, the discordance is fairly small, but certainly this can be a challenging diagnosis for a general pathologist, say somebody that does not necessarily focus on myeloid neoplasms or hematopathology. It could be difficult and challenging. Again, these patients used to be thought to have essential thrombocythemia. And the distinction between the two entities is more recent. Again, I'm not a pathologist, but you will see some megakaryocytic atypia here. You'll see some depressed erythropoiesis. You'll see some increased granulopoiesis. So there are things that distinguish it, of course, from ET, but then it's not quite overt primary myelofibrosis. For example, the fibrosis grade can only be a 0 or a 1, not a 2 or a 3. The leukoerythroblastosis is usually absent. So there are all these criteria, but the distinction between these entities can be, somewhat challenging. When you talk about management, risk stratification, of course, comes in just like for any other MPN. And the way we currently approach it is we still, really risk stratify them for the risk of thrombosis. Okay, because again, historically, this group was felt to have ET, and because in ET the approach is sort of thrombosis centered, it is so here as well. And fortunately, the IPSET, the International Prognostic score for ET, which is really a both a prognostic score and a thrombotic risk stratification model, does work in prefibrotic primary myelofibrosis. That's been shown by the Italian group from Florence. So you can risk stratify patients for thrombotic risk using the IPSET and manage them accordingly. But I think the bigger question here is that we know this is a more advanced MPN than ET. We know it's not quite as advanced as overt primary myelofibrosis. So what can we do to intervene at that point? I think there is a lot of interest, particularly on the part of patients, younger patients in particular, in that regard. So I think that field is just starting to expand and grow. There is interest in interferon, particularly ropeg interferon alpha 2b, which is approved for the treatment of polycythemia vera under the name of Besremi, is being studied in this condition. In fact, there is a study that's underway and has been presented a few times. So that's an important data set to watch. And then there are also other very innovative approaches coming down the pike. For example, vaccine approaches. There is actually one in the clinic for patients with early myelofibrosis, and then there are new drugs which are not yet in the clinic, but say target mutant specific, target specifically, I should say, mutant CALR or mutant JAK2. These might be of interest in this early phase of the disease. Now, one quick comment I'll make, just so that our listeners are clear and we don't confuse the two entities, is that sometimes prefibrotic is also referred to as early. And I'd like to draw the distinction that, at least to a clinician, the word early is a broader term, and it's not restricted by a pathologic definition, whereas prefibrotic is a pathologic entity. I prefer not to call it early, because early to many of us clinicians also carries the connotation of just being clinically early in the disease course. So one could refer to an overt primary myelofibrosis patient as having early myelofibrosis, simply because they are early in the disease course. So hopefully that makes sense, and I just think that's important to keep straight. There is a group within prefibrotic primary myelofibrosis who have a worse outcome, who are not going to have that 15-year median survival I was talking about. And my colleague Lucia Masarova and our group actually have presented some data looking at our database on who these patients might be, who pathologically have prefibrotic PMF, but really their clinical course and behavior of the disease is more aggressive. So, that is definitely out there. And there's also a paper from Dr. Coltro in Italy, finding that if these patients are cytopenic, which is uncommon in prefibrotic PMF, but if they're cytopenic, they're going to do worse. So, that sort of data is there. Again, currently, management of prefibrotic PMF would primarily be based on thrombotic risk. But I think, like I said, we probably need to move away from that and look at disease-modifying therapies to see if we can intervene at that earlier stage of the disease and really make more of a difference to the underlying course than we currently do when we intervene later in the course of the disease with JAK inhibitors, which is the current standard of care.